Hi there, welcome to Ask the Chiropractor, your source for ultimate health, healing, chiropractic, and medical related information. I'm Dr. Adam Rodnick out of Commerce Township, Michigan, and I'll be your host today.
And I'm Dr. Ruven Rubenstein out of Troy, Michigan, and I'll be your co-host.
We're here with our special guest, Dr. Robert Wood.
Why, thank you, fellas.
How are you, Robert?
He's out of West Bloomfield, Michigan. Dr. Wood is a dentist, been practiced for over 40 years, a general dentist who now has a specialty where he works with the temporomandibular joint, or TMJ, or the jaw. And we'd like to know, how you went from the beginning of your career, starting in general dentistry, to becoming such a specialist in the TMJ.
Well, I'm not sure we have all afternoon to talk about that, but I started very serious restorative dentistry. And I realized when I'm doing all this fabulous dentistry for patients, I better know what's going on with their jaw joint. Can you imagine the disaster of providing patient with thousands of dollars worth of dentistry and having the joint dislocated? You're just looking for a disaster. So I started educating myself on TMJ, but you have to understand that was a new modality in the 70s. We really didn't know much about TMJ, even coming out of dental school, because the population, this is the first generation that's keeping their teeth all their life.
Yeah.
So that whole modality flourished in the 70s and early 80s, and I guess I was right in the middle of it. And I started treating patients very early, and I realized that I might even have a little bit of the problem myself. So it has evolved. You learn this, you learn that, and you learn, and all of a sudden you've kind of completed the whole cycle. And the TMJ seems to be building. There's so many people that are being injured today in car accidents, falls, ice skating falls, even with domestic violence. The TMJ is at risk for major repercussions, and we need to help these people.
I know we share a lot of patients just because of the same thing, because
same
we're in Michigan here,
Same
look
reason.
how often it's snowy, someone slips on the ice, they fall down, not only can they hurt the jaw on the TMJ, but of course it's going to whiplash the cervical vertebrae, could hurt the thoracic spine, could bulge or herniated disc in any number of areas.
Oh, yes.
And so it's very easy for us to end up sharing patients in that regard.
I need your help, and I'm pretty sure you need mine.
Absolutely.
And what are some symptoms our audience can look for that they may think like, oh, I have a headache, oh, I have neck pain, that they may not associate with TMJ? And at the end of the day, so what are the most common signs and symptoms for someone that has a TMJ disorder?
I think tension in and about the face, particularly the jaw muscles down here, these big closing muscles, they start getting achy. They can't chew things that are tough because they just wear out fast. The muscles just seem to like they're always tense. And then they might have a little noise in opening and clicking on their joints. And it progresses from there and gets more severe. Of course, radiated pain to the headaches. They might have
You see
temporal
ear pain
headaches.
as well?
Sometimes the ringing in the ears, not so much ear pain. I don't see a lot of ear pain, but I see a lot of patients with ringing in their ears, and that seems to be associated with a jaw position, which is altered after an injury of this nature.
So we get a lot of patients that come in. You mentioned this clicking sound. We get a lot of patients that come in and they always are mentioning the clicking sound. In our office as a chiropractor, we're focusing on the spine and those structures. I know I focus on the upper cervical spine, your atlas, your axis, this little guy right here, and a lot of the muscles that come up from the axis, it connects to the condyles in the skull. And when I adjust that, sometimes it relaxes those muscles and it gets some relief, but at the end of the day, a lot of the times that clicking will maintain. Correct. So can you explain to us what that clicking is and how we can treat that?
Oh, absolutely.
Maybe a little anatomy lesson, Doc. We got a perfect thing here.
First off, I think our audience...
What's your skull's name? That's what we need to know first.
Oh, this is Henrietta.
Named it a woman.
Well, it is a woman.
It is a woman, yeah.
Good.
It is a woman. You can tell by the orbital ridge here that's very smooth. This is this is a female skull. The joint that we're talking about is involved with the two principal bones, the mandible and the temporal bone, this large
Hence temporal mandibular.
temporal mandibular, and the joint, which is the connection between these two structures. That structure has a little teeny disc that fits right in between those structures. I don't think I'm going to be able to get it there.
Very similar for our audience to the discs in the spine. Really, the only
Yeah,
couple of places we have discs
yeah,
are
and
spinal joints
not only the
and
spine,
TMJ.
but the knee.
Yeah, the knee.
Very
the
similar to the
Meniscus.
knee. Okay, but this joint is a little different. That it only joint in the human body that has a hard flexural stop, biting of the teeth.
Yeah.
So when the teeth are together, the joint is in a healthy condition, is in this position. Unfortunately, there's a lot of injuries that are caused by patients grinding their teeth, and they grind them and grind them and grind them, and they grind them flat, and they also grind them closed. And when they grind them closed, what happens is the joint starts going posteriorly, which is that's
backwards.
Backwards, and that's where all the nerves are and the blood supply. So when it gets to the point where they actually have pain, tenderness over the joint itself, we have an inflammatory response in the back of the joint. So that radiates pain all over the place. It radiates pain up into the head. I'm sure that when we have a dislocation of this joint here, I find all the time a contralateral dislocation of the sacroiliac. It goes all the way down the spine to the opposite side. So when we have this joint and this joint dislocated at the same time, we need both of our services in order to help these people.
Absolutely.
So if you're wondering why their disc isn't, why their jaw is not holding your corrections, is because we need to open the vertical dimension of in between the teeth. We have to give some space in here, so this condyle does not go superior, doesn't go up, and doesn't go back. There has to be space back there. Can you see how?
Yeah.
We need about 3 millimeters, 3.5 millimeters posterior and superior. Those tissues to survive appropriately.
So can this occur from normal wear and tear, or is it usually a trauma that happens?
I find most of the time it's trauma.
Yeah.
Trauma from long-term grinding of their teeth, trauma from falls, traumas from getting in domestic violence fight. A blow to the jaw can be incredibly damaging.
Yeah.
And so it's not so much wear and tear.
What happens also in, let's say, a severe type of whiplash? When the head goes forward, even if the jaw doesn't hit, can we have damage to the joint?
Yes, let me tell you what happens. We've had some
We see it with
beautiful
head
research.
trauma, with cervical spine ligaments. Without hitting something, we see a lot of damage, trauma to a joint.
When the patient's in a say an auto accident, and they're struck from behind, the blow forces all these ventral muscles of their chest and their neck to brace the lower jaw, but the head does this. It goes right back to here. And you can describe what's going on in the cervical spine at that point. But look what's happening to the jaw. We're hyperextending that range of motion for that joint. And it rips and tears the collateral ligaments.
Oh, yeah.
And we do the same thing with the
How does
cervical
it-
spine.
how-
As
what
you
is
get
it-
here, you go back like this.
Yeah.
And there's AL and PL,
Oh, yeah.
anterior longitudinal ligament here, posterior longitudinal
Got it.
posterior longitudinal ligament here, and they can shear and rip and stretch.
Yeah.
We have microscopic
Yeah,
tears
yeah.
that, if aren't corrected, heal wrong. So it's important that when someone does have any kind of trauma, whether it was ice skating or
I
car
concur.
accident or you name it,
I
any kind of
concur.
trauma, to get checked out
Yeah, they
get fixation taken
need
care of right
even-
away.
Yeah, they need care because what happens is the body is an amazing structure and it will accommodate to a lot of injury, but in that accommodation, they start to get into a scoliotic pattern, and then they start to getting the hips thrown out of whack, and then the knees go. Like my father used to say, one thing leads to another.
Absolutely.
The hip bone's connected to the
To
knee
the
bone.
knee bone, that's
Yeah.
right. And so the earlier these patients can get care, the better off they're going to be to prevent that accommodation dysfunction that radiates up and down the body.
Yep.
And then we have to treat the whole body.
Correct. The biggest thing we've seen is when you do have that auto accident, so we're taking a spine that should be in lordosis, in the cervical spine.
Yes.
And that whiplash occurs and you lose the lordosis. So all the musculature in the cervical spine gets pulled real tight. And where is it pulling on? Right on the mandible, right on that top few bones of your spine, so the muscles are real tight there. So as a chiropractor, one of the main things we focus on is making sure we restructure that
Restore the cervical
lordosis
which is
to
the
get it back
curvature.
to that normal curvature, to relax those muscles, relax those ligaments, and allow the body to heal properly. If your body's not functioning and healing properly, a lot of things are going to go wrong.
And for our audience to think of that normal curvature that we have in the spine, we want to think of it like a bridge that's going to have thousands of pounds of cars going over it. It's always built in an arc. It's a much stronger geometric structure than a flat line. And so we have a bowling ball sitting on top of a stick here. The head is heavy, the neck is small.
It
we
is a
need
bowling
the
ball. It's
normal
18
structure.
pounds.
You got it, exactly. We need that normal curvature to hold and support the weight of that properly, to not cause excess wear and tear on some joints and not others, and to distribute that weight evenly amongst the joints.
Very interesting.
So we look at the curvature on all of our patients. A lot of times when we take X-ray, we take a lateral cervical view to see that curvature. In our office, we actually have video cinematography, so we can take
You
a
showed
video.
me. You showed me that.
We
It's
can
very,
see
very interesting.
which joints are restricted, where there's
In motion.
hypermobility, where there's hypomobility, where the joints are moving because of ligament laxity as well. Like I said, with whiplash, when the posterior or anterior longitudinal ligaments are stretched or sheared or sprained, we'll see hypermobility in the actual segment upon motion.
Well, that's what we end up in the joint. We end up with excessive range of motion. And this joint functions for a lifetime in a normal range of motion. But if you hyperextend it in a whiplash or a fall, which pretty much gives it the same,
Same as
kind of-
whiplash,
same
yeah.
kind of
High velocity.
same kind of high velocity impact, and so we're stretching ligaments. And now we've got mobility, and what happens is that little disc that is attached to the outer pole and to the inner pole, those ligaments get stretched, and this little disc slips forward.
Could you hold that up, Doc, so the audience can see just this little tiny thing
It
in there?
isn't. Well, I tried to make this out of a little piece of plastic, and you can feel like it's biconcave.
You did a good job.
And it does fit in between here, but it's so small. The first level of injury in the TMJ is the lateral collateral ligament gets strained or stretched, if you would.
Which, if you're familiar, it's the same name of the ligament in the knee.
Correct.
Lateral collateral ligament.
Well, the knee and the jaw joint are the only two gliding, rotating joints in the body. Okay? And they're both weight-bearing. For many, many years, the debate was, is the TMJ a weight-bearing, load-bearing
It's got the skull.
joint? Oh, yeah, maybe 300 pounds per square inch
Yeah.
between the surfaces. So this little fibrocartilage disc is immensely important to keep those bony surfaces from breaking into bone on bone, which stimulates a destructive process of arthritic atrophy. So the first level is the disc slides to the medial because the muscles that are attached to it pull it medially. Okay. The second level, and we get a little click, and the jaw opens about so far, about this far, about 25 millimeters. The patient gets a little click, pop, and what happens is they've relocated onto the disc.
So the clicking's a good thing.
Clicking,
You want it
clicking,
to not click
clicking,
again.
Clicking reduces the dislocation.
Yes.
Okay? So that's at about 25 millimeters of opening, about here. Well, the next level of injury is where the lateral and the medial collateral ligaments get stretched some more, and the disc not only goes medially, now it goes anterior as well. And now the patient has to go to about here and slide the jaw somewhat forward, and now they click. Mm-hmm. But when they close, they silently fall off. So what we've designed as dentists to do is to shore up the occlusal, the biting surface of the teeth, put a little splint of some sort in between the jaws, so that they can't fall off the disc. Mm-hmm. And healing to as much extent as it can occurs. However, these structures are avascular.
Yeah.
They don't
Same as
heal,
spinal
they don't
discs,
shorten.
exactly.
They're avascular. So
For our audience, that means they don't have their own blood supply.
They have
Spinal
no
discs
blood
are the
supply.
same way. They
Yep.
don't have their own blood supply.
That's right.
So through good, normal, healthy motion, a process called
Yes.
imbibition, good things come in and bad things come out.
And what happens is when we get them back on, when we get the patient supported, and the disc is in place between the head of the condyle and the fossa, if you would, sort of like this, that disc recontours because it's fibrocartilage, and it will change shape to conform to the structure that we have. And that, by and large, really helps hold it on to the head of the condyle as it's going through its range of motion. Okay. Mm-hmm. And as the joint gets healthier, the arthrokinematics of that joint giving giving impulse to other muscles around the joint to splint it into place, hold it so it doesn't hurt itself more. It backs up and relaxes, and those muscles relax, and that helps the joint as well to keep the disc in place.
Yeah, I'm glad you mentioned that the disc can reshape. I've had a patient.
It really reshapes.
I had a patient came in, and she, on her filling out her form, it says TMJ, and I started speaking to her about it, and she said, "Oh, let's not worry about that. It's impossible. I have a flat joint." And I said, "All right." I said, "Yeah, let's see what's going on." And I only took care of her upper cervical spine, relaxing those muscles, helping get that structures back, help bring back the lordosis in her cervical spine. And within a few months, her face looked different. She had a normal bite again. And she went back to the dentist, and that cartilage, they said, "Oh, it must have reshaped around the condyles."
Yes, it
and
does.
It's no longer slipping out of place.
It adapts.
It adapts.
It adapts.
Now, what sort of imaging is the best for you, Doc, to get the perfect view? Do you do
MRI is the best because that's going to give us the position of where this disc is in the joint. We need to know that it's interspersed between the head of the condyle and the fossa, and the bulk of it is superior and posterior, and very little anterior to the condyle. Mm-hmm. That's a normal, healthy joint. When we see levels of injury, what happens is the condyle is being forced posterior, back, and somewhat up, and the disc is coming forward, and we're wearing the back side of that structure away. It has a very prominent ridge to the superior posterior border of that little disc. So that gets worn away, and we see on an MRI that now the disc is halfway between the posterior and the anterior, which means it's real thin in the middle, but it supports that quite well. And as it gets more damaged, we see the disc is moving forward, and finally when it's like a closed lock and the patient can no longer open their mouth all the way, they go maybe get to about 35 millimeters, maybe 37.
It's a hard stop there?
That's it.
That's a hard stop, huh?
Now what's happening is as the
right into
condyle
bone.
is rotating and then translating, it's all bunched up in front of the disc, and the poor little disc is just getting bunched up like an accordion. It's just getting scrunched. If we can get to it soon enough, like within maybe a couple weeks, a lot of times we can manipulate that back into place, and support the patient's occlusion, their bite. They have to have some sort of orthotic immediately, and it has to stay in place for maybe a week before they can even touch their teeth together. Well, that disc will just be gone.
Yeah.
Just that fast.
And when you guys use the splints, do they use them 24 hours a day? You have them just wear them at night?
Depends on the level of injury.
I mean, if the injury you were just talking about, you're
That's
talking
24
about
hours. That's,
That's a 24/7.
Yeah.
That's a 24/7 for a period of time, maybe a couple of weeks. And then we can start taking it out, having a patient chew, put it back in.
so it's a liquid diet for the...
Oh, liquid diet for a couple of weeks.
Good. So you get your teeth fixed, then you lose a couple pounds, you know?
Hey, not bad.
So we're talking about soft tissue structures. And we talked about auto accidents earlier. And I want to explain to the audience that if you don't break something in an auto accident and you don't have blood gushing from your head, it does not mean that an injury has not occurred. Whiplash can occur at 5 miles per hour from a car. You're talking about 2,000-pound objects slamming into each other. The force is going mostly into the person's body. And most people, they say, oh, I didn't get injured in the accident. It was a minor accident.
Yeah,
There's
minor.
no such
Or even
thing as a minor accident.
Or even we'll see that, let's say there wasn't much damage to the
But how do
car,
you-
they think it wasn't the body. Meanwhile, if the car didn't have that much damage, a lot of the force was
Goes into the-
transmitted into the neck, into
Absolutely.
the jaw, where a lot of times when there is more damage to the bumper in the back of the car, the newer cars are made to crumple and fold and crumple and fold and absorb some of that
Correct.
impact. But the old Buick boats, those ones are, you take a little hit in those, it's all going right to the neck.
Yeah, and most soft tissue injuries take a lot longer than a hard tissue injury. You break a bone, in 12 weeks, that thing is most likely going to heal in its proper position with a cast on it. Soft tissue injuries take about 6 months to a year to start the healing process.
You asked earlier about my background, and I spent 10 years studying at the medical school in Pomona, California, under the auspice of some world-famous osteopaths. Dr. Viola Fryman, God bless her soul, she passed about 3 months ago. She was 96. What a wonderful lady she was. And we dealt with soft tissue all the time, fascia, fascia, fascia. And we were trained craniosacrally, dentists. There's about 200 of us in the country.
Not that many, yeah.
About 200 in the country out of 30 million, that's not a lot. There's 2 of us in the state of Michigan, I happen to be one. And, and we start dealing with that energy impact into the fascia right away. Matter of fact, every time I palpate a patient, that energy comes out instantly. It just starts coming out right away.
Yeah.
And it's there from birth. I had the opportunity to witness Dr. Fryman treat a newborn. He was colic. He was screaming bloody murder. He was purple. He was screaming. Oh, he had a good set of lungs on him, I'm telling you what. And she set this little tyke down on the treatment table and just supported his back of his head and supported him here. And this little tyke started to wobble, and he started to wobble and wobble and wobble and wobble. And he actually had so much energy in him. He was just going like, I can't tell you how fast. That was just like crazy. And I was standing right next to her, and this little guy, all of a sudden his hands opened up and they just dropped. His color came back, baby fixed. Here's what was the problem. The connective tissue absorbed so much energy going through the birth canal that it compressed the condylar portions of the occiput at birth, which is separate, and the vagus nerve goes right through those condylar portions. And this little tyke, had vagal nerve complications at birth.
Yep.
She saved, in 30 seconds, she saved this child from a lifetime of misery.
Absolutely.
And that's where I learned how much energy the connective tissue that lines every bone, every space, every vessel, every muscle in the human body, every organ, it wraps up. And you're talking about injury patterns. That is systemic from the head to the toe.
Yep.
Absolutely. That's why we put a lot of emphasis on that upper cervical area.
Oh,
Atlas,
well,
axis,
sure.
occiput.
Oh, I know. And that's where it all focuses, because of the mechanics. It's really going to focus right in that area.
We have a few minutes left, Doc, and I tell a lot of our patients in general, especially people that have no experience with chiropractic at all. They come in, they've never been to a chiropractor, really don't have many preconceived notions. A lot of times I'll use examples comparing and contrasting us with dental care. And you can maybe elaborate on this a little bit, where I'll tell them, if someone has a toothache or pain in their mouth, of course, they want to go to the dentist. But they also go to keep their teeth clean, and they also, importantly, brush and floss at home. We see a lot of times with people's spines, they don't think about their spine until it's a toothache of the spine.
Yeah.
People don't take care of themselves. They don't keep good posture.
All
they do is bad things. They sit there like this on their phones all the time, their computers all the time.
They're hyperextending on that computer board day in, day out.
So we encourage people, obviously, to come in to see us when they have an injury, but we also encourage people to maintain a healthy spine, correct their spine.
Prevention.
I couldn't agree with you more. I think every individual should have a biannual tune-up.
Yeah. Absolutely, absolutely.
I get a tune-up in the spring so I can play golf.
Yeah.
And after I play golf all season, I need another tune-up.
Right, there you go. Exactly.
Yeah, every talk I give, I start off the conversation, who brushed their teeth this morning? Everyone raised their hand. I said, that's oral hygiene. Who did any sort of spinal hygiene today? And no one raises their hand. And I said, so I make everyone, no matter where I'm talking to, a bunch of factory workers, to a bunch of teachers, I make everyone stand up and we teach them spinal hygiene. I said, these exercises should be taught to your children at the age they start brushing their teeth. It takes about as long to brush your teeth, if you're brushing your teeth correctly, to do these spinal hygiene exercises.
I think that's fabulous.
I don't tell them to do one instead of the other. Do both of them.
Or we
Add
go
that to
to
the
schools
repertoire.
to do this. We do it with
Maybe
Boy
you
Scout,
teach
Girl
me.
Scout troops.
I'll love
Absolutely.
to teach you.
Yeah.
We'll teach you, and then you can teach your
your
patients.
I can teach my
Teach your patients. Teach
I mean,
them.
I have some stretching exercises that I do, but
there's some 3 simple exercises that we teach no matter where we go, and these exercises really help strengthen the muscles behind the neck, strengthen the ligaments to get everything nice and strong to maintain that normal posture. Because what we said, the structures dictate the function. If the structures are
patients
off,
don't know what normal posture is anymore.
They don't.
This
is normal.
This is normal. Yeah.
And even just seeing
this is shoulders,
rounded, head,
the
Z
airway
translation.
compromised. Oh, I see it all the time.
even just seeing on a model is good. They don't understand that this would be normal. Curving this way, curving this way, curving this way from the front straight. Most people wouldn't even realize that.
No, I mean I see patients.
It's not supposed to be straight from the
I
side.
see patients.
It's
You know,
supposed to be curved.
they're so straightened here. Their head is out in front. Their neck is straight like that. So what
Forward
happens
head
is
posture even farther like this too. We'll see.
the meatus is way out in front of their shoulder. Okay, they're way out.
That's
in
the
front,
ear.
Way out in front. Oh my God.
Yeah, and we'll see.
We'll send those ones our way.
We see these kids that when their head goes like this, their jaw starts jutting forward and they start getting underbites.
Oh yeah.
That underbite causes the Z translation, the slip. They're going to start getting that TMJ issues. These kids are going to start getting headaches, start getting neck pain, all these things.
Very much so. All the time.
I've enjoyed sitting here and talking to you. I think this is going to be great to know that I have someone that I can send that is one of 2 people in the whole state of Michigan that does these procedures. One of only a few in the whole country, so it's awesome.
Well, thank you for having me, guys.
Absolutely, our pleasure. So again, this is our special guest, Dr. Robert Wood out of West Bloomfield.
Thank you, guys.
Dental and TMJ specialist. And I'm Dr. Adam Rodnick out of Commerce Township, Michigan, and I've been your host today on Ask the Chiropractor.
And I'm your co-host, Dr. Ruben Rubenstein out of Troy, Michigan.
We'll see you next time. Stay healthy.